get to IMU, but she accidentally went to 4 West. And they were like, no, you missing, you don't have enough numbers. I think she only gave you 2 digits. And she was like, they said I gotta go to a 4, and I went to that 4, and they said it's not it. So what did I do? I walked her all the way in IMU and hoped that that was the right place, and it was. And then they all smiled, so it looked like she did this before. They were like, he's over there. She said, thank you.
All right. So,
real quick.
Yeah.
You already told me about the concept map to follow?
Yes, to follow along with the concept map.
Okay, cool. All right, do you think?
It's already recording, so I'll just edit all that other stuff out.
Oh yeah, and my nonsense talking. Did
Oh,
they get that
I did
too?
record it.
They got the caring story.
You got the caring story.
I'm so
Look at
sorry.
you. No,
Give her
I
an
love
A.
it.
No, okay.
Okay, so today, like I said, my name's Alyssa. I am a master's student in nursing education, so I'm trying to get my master's in nursing education. I graduate this semester in May, and so part of it, we precept in Practicum 2 with a nurse educator. I am with Alicia Carrier, but she's lent me to Alicia for today to teach you guys about anticipation and care needs, and we'll kind of get into that. Like I said, please participate. If you have any questions, just stop me in the middle. It's very casual, not super stressful. We can talk and see if there's any questions, you just holler at me. Okay, so hopefully today you'll be able to learn how to apply the didactic education you learned here, what you learned in nursing school, into real life scenarios with your patients, and kind of get some background on anticipation, how we anticipate things as nurses, and I'll get into it a little bit further. But part of nursing in your new grad orientation phase is learning how to critically think. You learn all this stuff in nursing school, and now you're learning how to apply it, right? How to apply all that knowledge that you learned when you see your patients. So we're gonna be doing that today. Like I said, some things is anticipation. What do you expect to see when you get a report on a patient? If I have a patient, I've been told by a nurse that a patient is seizing in room 5, and I go into room 5, I expect them to be seizing, right? I don't expect them to be sitting up talking to me because they said they were actively seizing, right? So things you can anticipate, and we're gonna go through with your concept map on risk factors, signs and symptoms, and we'll talk about it out loud. So just shout out everything you think would fall under that category. And we'll go from there. So we're gonna start with MI. What is an MI? Myocardial infarction, right. So it's broken up into acute coronary syndrome. I'm not gonna really go back to nursing school with you guys. If we need to, I'll definitely go into detail, but we're gonna talk about what we see in hospitals. Acute coronary syndrome is kind of the umbrella term. ACS is the umbrella term for NSTEMI, STEMI, angina. Angina is just chest pain with high risk. So what can you tell me about NSTEMI versus STEMI?
One has ST elevation.
Yeah, one has ST elevation and one doesn't. What else could you say about them?
The treatments can?
Yeah, the treatment can be a little bit different, right? Someone that's having an active STEMI, they have the ST elevation. We're not going to be as, we're going to be jumping in immediately. An NSTEMI, we may not do that. The standard is a 1 millimeter in ST segment elevation. That's kind of the standard for it. But do both of them have positive cardiac biomarkers? So both of them have troponin, or one has troponin, one doesn't. What do y'all think?
One has troponin.
Both have troponin. So you're gonna have an elevation in troponin. Everybody's body is different, obviously, but those are some things that you can expect. They both have positive cardiac biomarkers with troponin, but you'll see some ST elevation. In an NSTEMI, you can actually see ST depression as well. So those are things you're gonna look at when you get an EKG, right? They're gonna tell you order an EKG. You or the tech are gonna be the first one to see it. So you're gonna not obviously call it a STEMI until the doctor reviews it, but you're gonna have some certain things that you need to do when you tell the doctor, hey, this may be concerning. Okay, so who are at risk? What kind of patient is at risk, or what kind of history do you think they have medically that would put them at risk for having an MI?
Previous MI.
Yeah, CAD, hypertension, previous MI. What ages? Yeah, you're not gonna have like a 21-year-old, they may have one, but you're kinda not gonna, that's not the first thing you're gonna go to. We call them differential diagnoses. So when you walk into a patient room and let's say in the emergency room, or you're working at a clinic or something, you might say, okay, what brings you in today? And they'll tell you chest pain. If they're 21 years old, my first thing when I think of my differential diagnoses for chest pain is not gonna be an MI, right? I may think a trauma or something else. But if a 65-year-old female came up to me and started telling me they have chest pain, MI might be the first thing on my differential list, right? And what kind of patient would be not as obvious, but would be a high risk for an MI? This is that NCLEX kind of question you remember from nursing school.
Like diabetes?
Yeah, diabetes, a female, right? A female doesn't typically present like your normal MI case. They may come in and they may say, my stomach is hurting, I've got really, really bad indigestion. I have a history of GERD, but this is something different. And they're, maybe 45, 50. My instinct will be, do you have any medical history? They may be diabetic, and then I'm gonna be like, oh, this could be an MI. It may not be your typical elephant on a chest, left arm pain, it would be something else that is not as normal in your patient. So here's some examples. A lot of y'all called it out. We usually say about greater than 45 and greater than 55 in women, greater than 45 in men. Hypertension, like we talked about, hyperlipidemia, high cholesterol, right? If you have high cholesterol, you're predisposed for MI. We talked about diabetes. These are pretty common, but you're gonna have more of a sedentary lifestyle. You're gonna have more, if they're smoking, they have a high risk for constricting those arteries. Like we said, if they have a family history of heart disease or stroke, but they also could have had those things, those are your basic risk factors for an MI. What signs and symptoms? I kind of talked about a few, but what signs and symptoms would you see?
Shortness of breath.
Shortness of breath. Yeah, pain radiating. Okay, what else could you see? Not the obvious signs. Do it. Indigestion, yeah. Nausea, vomiting. They could come in nauseous. What if they come in and they're a little dizzy? Right? Those could be some things. So here's some you have your obvious chest pain, left arm pain, impending doom, but their heart rate's gonna be high, their respiratory rate's gonna be high. You may think that they come in and they are like having an anxiety attack. It looks like they're presenting like they're having an anxiety attack, but they're actually having an MI. That's something that you may need to work through. They may have low oxygen, they're gonna have palpitations, back pain. They could come in and have back pain. It could radiate. Pulmonary edema. These are some signs and symptoms that you might see in a patient that has MI. Who do you expect is gonna be consulted? If you get a report on a patient and they're coming in and you're getting a report from the night nurse, okay, you're coming in on day shift and they're saying, okay, we had a patient that had an MI, who do you think they're gonna be consulting on? Cardiology, yes, of course.
It's not like a consult, but you might be like activating the cath lab.
Yeah, cath lab. They may be getting a referral for cardiac rehab, right? Have y'all done MDDR yet?
Yeah.
Okay, so y'all did your MDDR, right? So you're thinking about that page. What consults could be holding up for dispo?
Outside of a physician, so
Yeah.
other
I have the answers up there.
people we have on the case that is helpful.
The answer's up there, guys.
So PT.
Well, like respiratory therapy.
There you
Yeah,
go.
they could have had some respiratory issues. You definitely want to consult nutrition or dietary, right? Because clearly their diet is not working for them. That's how we got to where we are, right? They could have the history of high cholesterol and they eat a lot of fried fatty foods. So having nutrition come and talk to them, because us as nurses, we could tell them all the things, right? We are all these things listed up here as consults as nurses, right? But we definitely need to get someone that's more in-depth and more detailed, that'll give them examples of what are, protein-rich foods, that we don't have time to sit there and list all the things, right? So you have the specialists come in, and those may be what is holding up your case. They may be cleared for dispo, but we're still waiting on nutrition. And that's gonna be your job to definitely expedite that.
Real quick, I'm gonna let them know what supportive med is, cause it's new to them.
Oh, okay.
So, cause that could be an answer to some other things in the future. So, supportive medicine is a, group of healthcare professionals here on campus. And they assist with either A, end of life care and those type of decisions, or they're helpful when you have an uncontrolled chronic issue. So you're gonna have patients that's been dealing with COPD exacerbation on and off for a long period of time of their lives, or dialysis, right? Kidney failure. And sometimes they're just tired. They wanna start minimizing the invasive procedures or the reoccurring hospital visits. So when you have those type of patients, or even someone where the family's kind of thinking about hospice or what have you, you can do a consult for supportive medicine, and it's a group of practitioners on campus that take it from there. So when I say that, I mean, they'll help make those decisions for the family and give them all the resources needed to make the decision to put the patient on hospice. Or they may help with that patient that wants to choose to do palliative care, which is, we're not giving up on everything, but we do want to minimize the frequent invasive procedures. So that's the difference between hospice, palliative care. Hospice is end of life care. So not everyone on hospice is going to be on their deathbed or looking near death. There's some that are tired of those interventions that keep them going, that they want to reduce from, and it could eventually lead to a shorter life. So for example, if somebody needs dialysis and they're relying on that for the kidneys to filter, and they say, you know, I'm tired of this. We know what could potentially happen, right? If the kidneys can't filter themselves, eventually that patient can go down. And if that's their choice, they can do that, but that's where we consult supportive medicine, and then they help set that hospice up. And then when you have a patient that may transition to, plans to transition to hospice, they'll have what you call comfort measures. And the order will be on that patient, and comfort measures is exactly what it sounds like. So if you have a patient, think about, if you haven't seen it before, imagine a patient is actively dying. Would you want to keep turning that patient to change them over and over and over again if they're incontinent of urine? So a Foley is appropriate for them because that's more comfortable. That way the bladder can empty with that device versus us turning, because it's a lot when your body's shutting down. Has anybody seen what it looks like a patient is actively dying yet? Or in a clinical or whatever, okay? Have you noticed that that's happening? Their body's shutting down, and that last breath they're working on is taking a lot to do it. So then they'll put orders in like morphine. And then this is a case where you want to shift your thinking, because morphine relaxes everything. And when you give that to that patient, it's going to help ease that end of life process. So when they're grasping for air and it looks pretty traumatic, they feel that. What you see is what they feel. So when you give that morphine, it helps relax that respiratory rate, and it helps relax the hard work that the lungs are doing, and help that process a little bit easier. So don't confuse that with giving a patient like maybe myself, God forbid, and you're holding your morphine for me because my blood pressure's low. That's appropriate. But for comfort measures, you're giving it for that reason, to relax the muscles, to help with that hard work that body is doing. So just kind of change the mindset of the two. The morphine is helping that patient, and it may result in maybe that patient possibly passing. The process is happening anyway, regardless. We can't stop that. But it helps it more comfortable. So giving it to a patient that's full cold and their blood pressure is low, then yes, you want to say something. You want to hold the medication, but it's not that when you have a patient that's actively dying. So you're going to learn that process along the way. But just know that when you have those type of diagnoses, like somebody with a STEMI, and it takes a toll to deal with that process, then you may consider supportive med, or you have somebody with uncontrolled COPD or uncontrolled, or a really bad stroke, right? You have a hemorrhagic stroke and it's kind of hard to bounce back from that, and there's not really a good quality of life, then that's where you can consult supportive med to help with that.
And that's also something as a nurse you want to be on your radar. If you have a patient there kind of suffering because supportive med hasn't responded, that may be another call that you make to call and say, hey, what's the status on y'all coming to bedside? My patient's not doing so great and we want to get that morphine for them so they're resting more at peace rather than suffering the whole time. So yeah, that's something definitely to keep on your radar. So what are some diagnostics that you're going to anticipate? So this is think imaging. What kind of things you're going to see for an MI? EKG for sure, right? What else? Okay, yeah, we're gonna get troponin for sure. Creatinine kinase. What is, we call it creatinine, CKMB. What is that?
Specific for cardiac.
Why? What is it? Yeah, it's damaged muscle cells, right? So you could actually have a patient, let's say, remember rhabdomyolysis? You may have a patient that's in rhabdo that they order a CKMB on. Are you gonna think cardiac? Maybe, right, if you see a troponin with it. But rhabdo is breaking down muscle cells, right? So their CKMB may be really high. That doesn't mean they're having an MI, that just means that muscle breakdown. So CKMB kind of gives us a little bit of how bad is this heart attack, how much muscle is being broken down, and what kind of damage are we looking at in the heart without doing any of the other diagnostics. So what else could we anticipate? CAT scan, right? A CT of the heart. We would probably get a CTA, right? The A stands for looking at the arteries. So they're gonna inject the dye in there so we can see the flow of the arteries. How easy is it for the blood to flow? You don't really get a necessary, an echo would be another thing we look for. They're gonna do an echo, which is the ultrasound of the heart. They may, if it was an NSTEMI, they may say, we need to do a stress test to see, that way we know how at risk are you for, and there's a couple kinds of stress tests. You have your nuclear medicine, you may see that order. You have one where they run on a treadmill, and we recreate stressing the heart, right? Not everybody can run on a treadmill. What if there was a trauma involved and they broke their leg and also had a heart attack at the same time? Really bad day for them, right? But also they can't run, so that's when nuclear medicine comes in. They're gonna inject a medication to make the heart rate jump up. That way it's like recreating them running on the treadmill. And see how easy can we go into an MI basically? What risk are we looking at? And then they may have to go get a cardiac catheterization. They may have to go get the cath because there's so much blockage. Usually in NSTEMI there's partial blockage, but a STEMI may be full blockage of an artery. So what kind of, so we talked about labs, we talked about troponin, CKMB. You may see lipids drawn, right? Because we're gonna look at those triglycerides, that cholesterol, and see like how, was that the cause? You're gonna get PT, we're gonna look at potassium. Potassium can put, if it's low or too high, it can put a person into cardiac arrest or an MI. So we're looking at the magnesium, we're gonna get PT, PTT, INR, platelets, and a D-dimer. Anybody know what that is? Clots, yeah, did that cause it? Because what you wanna do as a new grad, and this is what I have taught many new grads, you always ask why, right? Don't let it just sit there. Don't have a patient that's like, oh, they're anemic. That's their diagnosis. Okay, but why are they anemic? Is it something that they could do? Is it because of cancer? Are they anemic because it's just an iron deficiency and we can give them something for iron? Sometimes doctors have so many, nurses are kind of glorified babysitters for doctors, right? But sometimes they got so many patients going on that they're like, anemia, done, give them some iron and move on. And you're like, but why is the iron low? And that's your job as a nurse to say, to advocate for your patient and figure out the root cause, or else they're just gonna be back once you discharge them. Their iron comes back up, enough for a discharge, you discharge them, they go back home and it drops back at home, right? Because even though we're giving iron, it could be because of cancer and no one found that, right? So keep an eye on all those blood work. These are other things. BNP, what's a BNP for? Heart failure, yeah, beta natriuretic peptide. They may be seeing, did this MI put the person into heart failure? right? Do they have an MI because they've had really, high blood pressure for a really long time, and now the heart is giving out? So those are some other things you're gonna see. What meds do you give? Remember your Mona? You give nitro.
Oxygen, nitrogen.
Do you give nitro to STEMIs? Not always, right? It depends. It depends. Some providers don't follow it. What it does is it can decrease the perfusion, coronary perfusion. It could actually worsen the ischemia. Now, in reality, we think an NSTEMI would be ideal for it because it's not complete blockage, right? But there is some blockage and we need to get it through. Nitro dilates the vessels, we help perfuse. But in a STEMI, if it's complete blockage, there's nothing going through there. So we can dilate it all we want, we can try to get the perfusion all we want, but really there's nothing going on there, right? But so it basically compromises the blood flow. That's in a blocked artery case. Now, if they come into the ER, you're not gonna know if it's 100% blocked, 80% blocked. Like, you're not gonna really know that. So you may see it given, if you get a patient upstairs, you may see that it was given at once and then stopped because doctors were like, wait. But yeah, they're gonna be on aspirin. If you have a MI patient, you have your daily aspirin of 81 milligrams. That's the normal dose daily. So if you have a patient that comes in and they've had a history of MI, they may be taking, Bayer aspirin once a day, every day. But you may see 325 milligrams given in the ER. That's because that's what we give immediately when you come in. Cardioprotector, right? You have your nitro. We're gonna give statins, atorvastatin. Statins are to help with cholesterol, lipid buildup, right? We're gonna do O2, and then you may see some blood thinners. Why would we want blood thinners on this patient?
So it doesn't.
Yeah, it could either stop clotting, but you need to thin the blood enough. If you picture an artery, you've got some plaque buildup, right? You got plaque buildup. You need to thin the blood enough that way it can smoothly go through the vessels without too much back pressure, right? So we're gonna thin it because we wanna make the heart just went through something traumatic and we need to thin the blood that way it's as smooth as possible right after. Amio, you can give amiodarone to help lower heart rates. You're gonna see heparin. Every person, especially if y'all have already been with your preceptor, you're gonna see almost everybody gets Lovenox, right? Everyone gets the standard 40 milligram Lovenox injections. And that's because they're not moving. When you're at home, you're moving around a lot. So that means if they're not moving, they're in a hospital bed even more than they normally are, they're at risk for developing a DVT. And we don't want that, so that's your standard. But you may see an increase in your Lovenox dose and it's not your standard. You may see heparin, Plavix is another one, and then you may see beta blockers. To help with contractility of the heart and to help with lowering heart rate. What is our goal here? Very simple. Reperfuse the heart, right? The whole thing is that there was no perfusion, now we want perfusion. We want them to have no chest pain, if possible. We want their heart rhythm improved. We want oxygenation to be improved. Reperfusion aids in oxygenation. So those are all things that we want. Here's some pictures of some STEMIs, some NSTEMIs. You could have, like I said, in the bottom picture, you have your STEMI. The first one is normal. Your ST segment elevation is normal. It's less than 1 millimeter. But then you have your STEMI. You may have heard people call it tombstoning. Looks like a tombstone. And you may have depression in an NSTEMI, which that third one right down here at the bottom is the ST depression. All right, so here y'all have a STEMI rapid. You could have a patient that's upstairs that came in for something completely different, right? They've stressed themselves out so much, their blood pressure's so high, they have a STEMI rapid. So you're gonna want here, if you get the patient and all of a sudden you go in, there's chest pain, you get an EKG, you're gonna wanna call a rapid within 5 minutes, get an EKG within 10. 10 minutes is the standard, even when they come into the ER, 10 minutes is the gold standard for how fast we want an EKG done, right? Definitely tell the doctor because someone's gotta read the EKG. And there's some orders that are standard here for ST elevation in your protocol that have CBC, CMP, and all those labs that we talked about previously. Okay, so now we're talking CVA. I kind of gave you the answer, I guess, on the outcome, but what's a CVA? Stroke, cerebrovascular accident, right? Also known as stroke. Let's talk about ischemic versus, there's different kinds of strokes. Ischemic versus hemorrhagic, right? Those are the two that we see versus a TIA. What are TIAs? Okay, you know the name, but what is it?
It's a short stroke.
They're little strokes, right? The way we describe it best to the patients, because they don't need the whole pathophysiology behind it, right? You gotta tell them these are warning strokes. These are warning signs that your body could be experiencing a stroke soon. So this is your body's way of warning you and saying, slow down, eat better. And so those are things, they may be admitted for it. They may, if they have frequent TIAs, they may be admitted for it. Okay, now let's talk ischemic versus hemorrhagic. What's ischemic versus hemorrhagic?
Ischemic is like clots and hemorrhagic is like bleeding.
Yeah, clots versus bleeding. It could be not even a clot. Ischemic could also be just not enough blood flow to an area. It's tissue death, right? The death, lack of oxygen. Who is at risk for having strokes?
Hypertension patient.
Mm-hmm.
AFib.
AFib, exactly. Diabetes, yep. Yep, there's a lot. If it's too small to read, let me know. But smoking. What about, what would you think if you had a 21-year-old female come in that had a stroke? Birth control, oral contraceptives, as well as recent traumas. They may have been in a recent trauma. There's some kids I've seen that have come in for, they were involved in a fight at school and they developed a clot and the clot went to the brain and they had a stroke. Their poor circulation, they may have some vascular issues going on. Usually smokers, right? Inactivity, obesity, travel. Have you ever heard of the person that flew on a plane? That's your textbook NCLEX, right? Flew on a plane while on birth control, got home, their left leg started hurting, and then all of a sudden they had a stroke, right? That's your textbook. So those are some. What are signs and symptoms of a stroke?
Hemiplegia.
Certain side of weakness.
Mm-hmm. Right, one-sided
Aphasia.
weakness. Rapid onset headache, right? They have headaches normally, they may have migraines, but all of a sudden they have the worst headache everywhere ever, and it's just like bam, happens right away. Anybody heard LKW or LSN? So this is what we look for, especially in ER, but when they present to you, because we think that they're gonna have a stroke, then come to the ER, but they could have a stroke while on the unit, right? LKW is what's called last known normal. Or last seen normal. When was the last time you saw them that was normal? Why is that important? TPA. How many hours do you have? 4 hours. So if they haven't been seen normal in 3.5, we got to get going, right? We got to get this thing moving. If they were saw normal 10 minutes ago, you're good. You've got some time. But knowing that is really, really important for treatment planning. And doctors are gonna look at you and say, did you find out when the last seen normal was? When was the last time you were in there? Well, it's been like an hour since I was in there. Were they fine an hour ago? But maybe the tech went in recently and just did vitals. Were they fine when the tech went in? So you gotta start doing your detective work and asking the tech. Asking the family, were they fine a few minutes ago? Stuff like that. Here's some more signs. You got your facial drooping. They could be confused, right? You could be fine. They're not old, but all of a sudden they're confused. Nausea, vomiting, vertigo, obviously your numbness. Depending on what lobe of the brain is affected, you'll have different unilateral, right? Because what is it? The left side, where are they gonna have it?
Right side.
Right side. It's always opposite, right? But there's some things called cerebellar strokes that are kind of rare. It's the cerebellum. So it's not, you have your big brain, the cerebellum's the one underneath it. It's not on either side of the brain. It's down at the second brain. And they may not have these symptoms. They may just have your rapid onset headache, weakness, vertigo, but there is no unilateral weakness. They're just weak generalized. So different things like that. They could be sweating. Who do you think is gonna be consulted? First one. Neuro, obvious, right? Neuro. Could be because they have got some hypertensive issues, right? The hypertension caused them to have the stroke, so we're gonna consult cardio. When they have this stroke, they may have stopped breathing or had difficulty breathing. You're gonna call RT. Definitely need PTOT, right? Speech. What if your doctor tells you to go give aspirin right after the headache? What do you need to monitor? Swallowing. Can they swallow the pill? Your doctor may completely forget about a swallow study. Maybe completely forget them and they just be like, go give them these pills. And then they're sitting there with one side of weakness, like not able to even drink a sip of water, right? On any patient, you must document that they passed a swallow study or they were able to sip water before you just go and scan your pills that you did, right? Because then they're gonna be like, if they aspirate or they choke, they're gonna come back to you and be like, did you even check? Always come back to nurses. Everything you do, CYA. I know it sounds like a lot, but once you get your workflow good and your workflow gets, pretty consistent for you, these things come second nature. If you had a stroke patient, I'm not gonna give them anything till they take a sip of water. Hey, can you take a sip of water? Or maybe till speech comes and clears them. And definitely nutrition, because something caused a block and they're gonna need to either adjust how they're eating or eat better. What imaging are you gonna see? CT of the brain, right? For sure, CT. With or without contrast. With contrast, you may get a CT that shows nothing, but a CTA shows something. Because the A is what's giving the blood flow to the arteries, and then you see something was blocked. We're gonna do some Dopplers. Dopplers of the carotid, Dopplers of the lower leg extremities, which are basically like ultrasounds, because was it a DVT that caused it? Again, why? Always asking your why. What caused the stroke? You don't just say, okay, let's treat the stroke and move on. What caused it? They may have had some DVTs. You got your EKG, and then you're gonna get an echo, of course, to see if it's like something to do with the valves. Maybe like you said, AFib. They may have had AFib develop the clot because their valves are a little wonky. So these are some diagnostics that you're gonna see. Blood work. You're gonna see your basic coag labs, right? You're gonna see your PT, PTT, your INR. B vitamins. That was something that I learned recently would help reduce cell plasma concentration. So they're gonna be some things that are gonna need to be monitored. And we talked about D-dimer because we're gonna see if it was for sure a clot. The reason we go through these is because as a nurse, like I said, you're the babysitter. Doctor may put in standard stroke or protocols, and they may leave something out like a D-dimer. And it's your job to say, hey, do we wanna get a D-dimer? Oh yeah, we do, okay, great, thanks. Same with the NIH score. That NIH score is what's gonna give you the doctors are gonna calculate it for you, neuro's gonna calculate it, but you may wanna know and be familiar. Yearly, you'll have to do your modules, your NIH modules. Do y'all have that here?
Sorry, what?
Your NIH modules that you have yearly?
Yes.
Yes, yearly you'll do an NIH module, and it's to see how bad is this stroke residual, like what are we looking at residually, right? NIH, what is y'all's protocol here? NIH of what would get TPA? Like 6
Yeah.
or up?
Yeah.
Yeah, there's usually a score protocol at every hospital that says NIH of this, we're gonna consider giving TPA. So medications, I said TPA. What else do you think you'd get?
And that's with the new onset, by the way.
Yes,
Not
new
the
onset.
routine, NIH assessments.
So you're gonna have stuff different from a ischemic versus a hemorrhagic stroke, right? An ischemic, I'm gonna see someone that comes in with some antiplatelets. I'm gonna see them come in with Brilinta, Plavix, aspirin. Am I gonna wanna give that to someone who had a hemorrhagic stroke? No, right? But guess what comes in your standard admission orders? Lovenox. They came in, I got a hemorrhagic stroke, and the doctor accidentally put those things on their aspirin, those kind of things. That's your job as a nurse to say, I'm holding this. I'm gonna talk with the doctor. What are we doing? What's usually the way I word things is, what's the rationale behind giving the aspirin, right? Because you don't wanna be like, why are we doing this? Because then the doctor doesn't get defensive. So what's the rationale behind what we're doing for these medications? And then that'll get that conversation. But in a hemorrhagic stroke, you may need to give an anticonvulsant, right? Maybe they had a seizure when they had a bleed. Some hypertensives for sure. Isosorbide. That may be one of the medications that's an osmotic diuretic that we're watching to help because they've got so much inflammation, and we're looking at that in the brain, right? And then they may need surgical interventions. They may have surgical interventions if it's a hemorrhagic stroke. They may need to stent something if it was ischemic. So those are things we need to monitor. And obviously, I gave you the answer, but we're gonna increase circulation to the brain, right? We wanna decrease any risk of having another stroke because not only are you at risk for strokes because of your risk factors, but now we're at risk because you're doubly at risk because you've had a stroke now. You're at risk for having another one, just like if you have a heart attack. We wanna make sure we're improving speech, but we really wanna improve their day-to-day life. Were they very active before and now they're not? We want to get them back to their normal as best as possible. Not gonna happen in a whole admission stay, right? We're gonna get them back to 100. But we're gonna make sure that we get PTOT involved, and that's also on your MDDR, things that were pending. Excuse me. Okay.
We're all nurses.
And know your B fast, because it may happen for you on a unit. Their balance, eyes, face, arms, speech. It used to be fast, just your fast rate, but now it's B fast because we include balance and eyes in that. And you may have to call a rapid if it happens to you on the unit. Hopefully it never does. All right, all of these patients that we're listing are typical of your patient population here at this hospital. So these are all things you can see, expect to see. They're not just random patients that we've picked out. These are all ones that y'all see commonly that your educators gave to me to break through. What's COPD? Yeah, right? So we are going through, it's inflammation in the lungs. Remember, it's irreversible. And it's usually caused by what? Smoking, right? So you've got people that are smoking, chronic bronchitis, air pollutants, and mold exposure could also be a factor. So maybe you have a patient that has COPD, and your initial thought is when I go in there, I'm gonna ask them how often they smoke it. They say they don't smoke at all. Okay, where do you work? What kind of exposure you have? Those may be questions you need to ask. What do you see signs and symptoms in this patient? Okay.
Breathing pattern.
Remember your nursing school here. What do they look like? You got that pursed lip breathing, right? Because they're like, their body's teaching them not to take in too much oxygen. Because remember, you can't give them too much oxygen because then that's the trigger, right? Oxygen is their trigger instead of like CO2 being it. And they may be tripod. Remember that tripod position? They may have clubbing in their fingers from lack of oxygen. They're basically in a permanent state of hypoxia, right? We could never live at that level, but they've adjusted, their body's adjusted and compensated. They have issues with sputum. They're not able to push out sputum due to the inflammation in their lungs. So they have maybe a change in their sputum. Who's consulted on this? Respiratory. Who are the doctors? Pulmonology, yeah. You may need a case manager. That may be on your MDDR. You're waiting on case management to get them oxygen home. They need oxygen to be at home. Nutrition, you have to change your diet when you can barely breathe, right? So they need to make sure that they've got the great diet. And then you need PTOT because they're so hypoxic, they may have difficulty. It takes so much energy just to put on their clothes. So you may have those things going on. What imaging could you anticipate? Do what? X-ray. For sure. You want to see X-ray? You may need a PFT, maybe pending that pulmonary function test. Let's take a look and see how how bad are the lungs off? Like how bad off are they, right? What is the function of their lungs? And then a CT of their chest as well. Some blood work, ABGs. What is their PO2? What is their PCO2? White blood cell count. A lot of times bronchitis can cause, you're looking at infection in addition to COPD. So we're gonna check those white blood cell counts. Why would we need blood cultures? What do blood cultures check?
The organism causing the infection.
The type of infection. What do you need to make sure as a nurse that before you do blood cultures has not been done? Antibiotics. Antibiotics. You need to make sure antibiotics are not given before blood cultures. And if they are, you need to tell your doctor and send them a message, say, would you still want me to do cultures? They're probably still gonna want you to do cultures. But they may have gotten antibiotics in the ER and now they're up to you and you've got the order for blood cultures. So just communicating that these cultures were given with broad spectrum antibiotics is something that's important for you. Same with sputum. You may have them, I like to call RT because every nurse has their like ick, right? My ick is sputum. That's like my thing. I can have blood, poop, pee, I can have brain fault like in my hand from a traumatic injury, but if you got sputum, So, and if it's not as easy to get a sputum culture, you're having them cough and spit, but they're not, it's all dry, remember, because COPD doesn't really give that the best of sputum. You may need to call RT and ask them to help. They can give them some liquid and put, like, they work their magic, RT does. I've had to do that before. What meds?
Inhaler.
Mm-hmm.
Steroids.
Bronchodilator, steroids. Yeah, we got inflammation. We need to decrease inflammation, right? Nebs. They may be on routine nebs. Yeah, you need to make sure that if you, as a nurse, you've got orders for nebs, who's doing that? Is RT gonna do them? Are you gonna do them? And if RT is good, do you need to call RT and let them know, hey, we have meds due in 30 minutes? Or hey, the nebs that were ordered an hour ago and we still haven't gotten them. We need to make sure we do that. We don't go over 92%. Too much oxygen triggers with them, remember that? And something that you may want to think about is a nicotine patch. They still may be smokers, despite them having COPD. That happens so often. And you're like, dude, can't even breathe. And the good oxygen you are getting is from a cigarette, but you may need to give them a nicotine patch because they're on oxygen and we don't want the hospital to blow up, right? So you may need to order a nicotine patch for them. And of course, if it's related, an infection is going on, antibiotics. Outcome, like we said, the tripod breathing. These are my favorite pictures from nursing school because they're just so descriptive. You may not know all the things, but if I can picture that person of the drawing, that's what they look like. You got your tripod breathing with oxygen, you got the cigarette next to them, right? These are all things, they're gonna be thin because their body's working overtime. But these are some things you can anticipate. They may have a barrel chest. But we want to get them back to as normal as possible. Again, hemodynamic stability with clear lung sounds to the best of their ability and improve their airway and get back to getting that activity back to normal. Any questions on these so far? No? Okay, we'll go to the next patient. This one is pneumonia, but we're going to talk about COVID here because a lot of it was COVID pneumonia that we're seeing and still see some in some of y'all's patient population. What is pneumonia and what's COVID?
Pneumonia is a bacterial infection. COVID is viral.
Yeah. And what was COVID?
Never heard of it.
Is it's virus, right? So we're looking at bacteria versus virus, but a virus can get bacteria and it can turn into COVID pneumonia. That's what a lot of people get admitted for. You don't really see in the ER anymore people coming in with just viral COVID. If it is, you see them admitted for COVID-related pneumonia, especially in our older population. Who do you think's at risk for pneumonia? I just gave you an answer. Older people, okay. Okay. Immunocompromised, that's what I was looking for. Comorbidities, right? Smoking, heart or lung disease. People that have GERD are actually pretty high risk for pneumonia. And previous COVID positive. You've heard of long COVID? Have you heard of long COVID? They may have had COVID exposure a year ago and they still are having effects from it, whether it's clot related, if it's pneumonia related. Long COVID is something that we've seen. What are signs and symptoms? Go with your obvious. Flu-like symptoms. I mean, coughing, right? We're gonna have people that are coughing. It could be dry or it could be productive. What's a productive cough? Sputum, right? So if you've got productive cough, what do you think you're gonna see in an order? Sputum culture, right? Sputum culture is something you're gonna see. You're gonna have some pain, chest pain. Have you ever been sick and had a really bad cough? Because the cough is the last thing to go, right? You could be back to normal but have a cough. You got chest pain. Your chest wall is tender. They may be confused. They may have those typical runny nose. You got your loss of taste and smell. Some COVID patients have that, some don't. We got to monitor for PEs, pulmonary embolisms, and blood clots because those were really common with COVID. COVID was clotting people's blood. And so when you're got clots, you risk PE. Who's consulted? Think you're obvious. RT, yep. Pulmonologist, yep. What's one that you may not think about, but once we say it, it's obvious? Infectious disease, yep. You're gonna see ID may be consulted. You're gonna see ID a lot more than you think on the units. They may just be for MRSA. You may have ID consulted, or it could be for pneumonia, right? It could be something as simple as this. We could be cardio. Cardio could be involved. Maybe their pneumonia is causing them some issues with their heart. PTOT, always. PTOT is kind of one of those standard. You're gonna see that with pretty much every high-risk patient. And hematology. Hematology may be something consulted because of clotting. ID, yeah. Infectious disease, sorry. Infectious disease ID. What imaging?
Chest X-ray.
Boom, chest x-ray. CT of chest. Your COVID swabs, right? Even pneumonia that comes in and we don't know if they have COVID, we're gonna swab them just in case. You're gonna get your COVID and flu combination swabs. Blood cultures, right? How bad are they septic, right? Are they septic? Your basic CBC, we're gonna get ABGs. Who do you call for ABGs? RT will be doing your ABGs for you. Arterial blood gases. Lactic acid. INTLK was on here. What do y'all see INTLK stand for you? I didn't have that on. That was on INTLK was on Alicia's.
Oh, like the interleukin.
Oh, okay. Those would be seen in your COVID patients. Lactic acid. Why would we draw lactic acid? So what is lactic acid?
Make sure they're not becoming septic.
Yep.
Talk about that.
Yep, you talked about it. It's really testing you the inflammation and how bad it caused sepsis. We talked about procalcitonin. If they are high risk for sepsis, it can be indicative of bacterial infection. We talked about on here, it's listed cytokine. Oh, I didn't list it, but CK because they could be in a cytokine storm due to all the inflammation that's going on. COVID really causes just like widespread inflammation everywhere. All right, what meds? Antibiotics.
Would you give steroids?
You could, yep, all that inflammation. What did you hear a lot when people were getting COVID? Yeah, oxygen. Did you ever hear about remdesivir? Remdesivir is a medication for COVID. We gave a lot of Paxlovid. Paxlovid is another medication. That wouldn't be super severe. You may see remdesivir more on super severe COVID pneumonia patients. But Paxlovid is what they would get if you go to a clinic and you test positive for COVID. Think about Paxlovid like Tamiflu, right? Tamiflu shortens, it's not gonna cure your COVID. You're not gonna take it and be done with your COVID. But if you're supposed to have COVID, your body doesn't have COVID for 7 days, you may have it for 3 to 4 days instead. Paxlovid acts as the exact same thing. We gave a lot of zinc, vitamin C, zinc and vitamin C echinacea with our patients, mainly zinc and vitamin C to help boost their immune system. Maybe on Eliquis blood thinners, that COVID could have caused some clots, so you're gonna see that. O2 and steroids like we talked about. But our goal is COVID negative hemodynamic stability. Those are our goals. We're gonna increase that gas exchange going on in the lungs. If there's an obstruction, we're gonna clear that. But this is kind of what your patient's gonna look like. When you do a sputum sample, one of the things you need to note, I don't know if y'all have a flow sheet or what is the color and stuff like that. Just like when you get urine, you're gonna note if it was bright yellow, clear, cloudy, you're gonna wanna note that too. Because what's something that could be really dangerous if you see in their sputum? Yeah, like blood, that's dangerous. When they have a productive cough, what do you think a PCP would look at, like doctors would look at in color to determine if it's viral versus bacterial? What color, right? Is it gonna go from yellow to clear? If it's green, I'm gonna think bacterial. So you're gonna look, and it's gross to look at, again, sputum's it's not my thing, but I still have to look at it as a nurse and see what color, because now I'm looking at, if they come in and they start developing pneumonia, we're looking at, okay, this may be bacterial. This may not just be flu that we're looking at. This may not just be COVID. We're looking now, COVID's turning into COVID pneumonia. Something as simple as just looking at a color of stuff. Yes, you're waiting on all these other diagnostic factors, but something as simple, you could tell something like that very easily. All right, any questions? All right, pancreatitis. What is it? Inflammation of the pancreas, yes. What does the pancreas do? Yep, digest food, helps with glucose. So what are some things we're gonna be monitoring? Glucose, right? Very simple answer, we're gonna be monitoring blood sugar. And we need to see what's going on. So, talked about it. Who's at risk for pancreatitis? Alcoholics. Your typical alcoholic may be at risk. Some people that have cancer, they could have had surgery. They could have had some trauma, high triglycerides. It could be also idiopathic. There could be no reason why they had pancreatitis and now they have it. Gallstones. Gallstones could block your biliary duct and cause issues with the pancreas. So these are all some things that puts them at risk. What do you see on a pancreatitis patient? Pain, nausea, vomiting, left upper quadrant. In the next slide, I'm gonna show you one of my favorite things, and this is just something I added. It was an abdominal assessment. If you have a patient come in and say, I have left upper quadrant pain, things to remember, and you can take a picture of it too on the next slide. But right upper quadrant, what are my differential diagnoses thinking? So if a patient comes in with pain in the left upper quadrant, one of the things I think of is pancreatitis, then my detective work kicks in and I say, okay, do you drink alcohol? Do you smoke? And if it is, if they are, pretty alcoholic, they're alcoholics, or they drink a lot of alcohol, they smoke, my differential diagnosis, my brain's gonna go straight to pancreatitis. That may be something, as you go through the process. As you see more patients, this comes with time. They may have pain that lessens in a fetal position, so you may walk into the room. These are those anticipation and those expected findings. If I have a patient that has pancreatitis, what do I expect them to look like when I walk in that room? They could be in a sitting position because laying down flat hurts them too much. Remember Turner sign, Cullen sign? Do y'all remember that?
Yeah.
Back in nursing school? Those are things I'm gonna look for, because those could be, the pancreas is bleeding, right? One of the biggest signs of pancreatitis, pain after eating, right? Within 30 minutes after they ate, you're talking to them and they're gonna have pain. So as a nurse, I'm on pain watch and I start thinking about those PQRSTs, right? What worsened your pain? I may need to be like, okay, if they're gonna have lunch at 12, I need to make sure I've got some pain meds in my list, because they're probably gonna eat and have pain, because we don't have surgery lined up just yet. Those are things you gotta start thinking about. Who's gonna be consulted?
Yeah.
GI? Endo? Nutrition? Surgery? Social work could be consulted. You may be pending social work. You may see psych on here. Some patients, we're gonna consult psych. Why would we consult psych?
If they have an addiction problem.
Yeah, addiction. They could be really bad alcoholics. We want to consult psych so that they can be followed and get all the resources they need. So you may be pending psych. Usually everyone's pending psych. So you may be pending psych. And something I want to mention that I didn't mention with signs and symptoms, fatty stool. The poop is gonna look greasy. I know that sounds gross, but you may go in after a patient goes to the bathroom and you're still trying to figure out what they're here for. They're admitted for abdominal pain that's not getting better. We're waiting on imaging, they got upstairs, or maybe they're in the OBS unit. Maybe you're working in the OBS unit, CDU, and you're waiting for stuff to come back. And you go, all you did again, this is one of those things you can look at sputum. You could look at their poop and be like, ooh, this might be pancreatitis. And that could be on your differential. Okay, so we did consults. What imaging?
Ultrasound.
You could get ultrasound. CT. CT's for everything, basically. CT of the abdomen and pelvis. Could be an MRI. We may want to look at those gallbladders. Who's heard of a HIDA scan? So a HIDA scan is kind of like a CAT scan that they assess the gallbladders, gallbladder, and the ducts surrounding the gallbladder. Why would we see a patient that's hyperglycemic? Like, why do I, as a nurse on a pancreatic patient, have to make sure their sugar is normal?
Do you
But the
understand?
pancreas is.
Yeah, y'all talked about it earlier. The pancreas isn't controlling sugar. That's something that needs to be on my radar, right? If I go after, I wanna make sure I go before they eat, check their sugar, and after. But the doctor may forget to put in any sugar checks or insulin or anything because they're not diabetic. But the issue is the pancreas, and the pancreas is not working effectively. So you may have to tell the doctor, remind the doctor for those things. We're looking at LFTs, amylase. We're looking at some liver labs. You're looking at some gallbladder labs, albumin. Like I said, sugar. You may have to ask for some sugar checks. It may not be as frequently, ACHS, but it may be like once a day, or however the doctor's wanting to monitor this. What meds do you take?
Pain meds.
Pain meds, I said it earlier.
Steroids maybe, antibiotics.
Yeah, more antibiotics for sure. Do what? You may see antiemetics, some Zofran, right? Because they're gonna be vomiting. Creon helps replenish those pancreatic enzymes. That may be something ordered. You're gonna give fluids, right? Because they need, it has to be dehydration. Protonics helps with acid in the stomach. And you may be giving insulin, like I said, because their pancreas isn't working. The goal here is no signs and symptoms. When in doubt, these are when you can tell when the pancreas is bleeding. You got Cullen sign, which is around the abdomen. It's kind of a turned picture. It's a bad, poorly drawn picture, but it's turned to the side. The C goes around your belly button, and the T is on the side. So those are some things you're going to be assessing for when you take a look at this patient to see the severity. Any questions with pancreatitis? This is the picture I was telling you might want to take a picture of. This is one thing that really, really helped me when I'm going through my differential diagnosis. Did you use something like this too?
No, I really like that though.
I was obsessed with this. I did this in my new grad, and I give this to my new grads. These are some things, these are when I was talking about differential diagnoses, these are the things you may think when a patient comes in and tells you, I have abdominal pain, and you ask where. If it's right lower quadrant, I'm gonna start thinking appendicitis, colitis, ovarian torsion, ovarian cyst. Those are some things I might start thinking of, and it helps you with your questioning, where you go in your questioning when you go through asking these questions, right? Y'all are gonna have a little bit more time than an ER nurse might, but asking those assessment questions, this helps me ask those questions and helps keep on my radar things that are important. If they have a ruptured AAA, or a AAA, which is an aneurysm in the aorta, I'm gonna ask about back pain, right? Because the aorta runs along that. But if they told me they have abdominal pain in the middle, that's maybe something I would have asked back pain. I may not ask back pain if I'm thinking it's an ovarian cyst, right? So something like this really, really helps you and kind of helps you look a little smart when you're talking with your preceptor about, because they may ask you, okay, she came in with right upper quadrant pain. What are we thinking? What could be your differential diagnoses? And this also helps you with your plan that you're gonna make as a nurse going on there. What am I gonna be looking for? What am I gonna be doing today? If it's right up quadrant, okay, gallstones, okay, what kind of meds can I anticipate to give? So all of that helps you anticipate what your patient is gonna have and what you're gonna need to do, which helps with your time management. If you can anticipate these things, your time management's gonna be really beneficial. Okay, diabetes and DKA. I'm gonna kind of give y'all some of these, but let's talk about it. What's the difference between diabetes and what's DKA?
One is type 1, and the other one is type 2.
Could be. Let me start with this question. Which is worse, high sugar or low sugar?
Low sugar.
Low sugar. You go to a coma faster with low sugar than you would with high sugar. Your body can tolerate high sugar a lot better than it can tolerate low sugar. However, DKA, you could still have a coma, right? So with DKA, it could take a while. What kind of, and I have the answers here, but let's talk about them. Who's at risk for getting DKA? Yes, they're type 2, right? Or type 1, but what are they at, what makes them at high risk for DKA?
No insulin.
Yeah, so they're non-compliant. They may not be taking their insulin. There's a lot of patients we see that are, they don't have a lot of money. So they have to stretch their insulin a lot longer than they would normally. So they're not taking as much insulin. they think it's still helping, but in reality, it's putting them into DKA, right? They're severely dehydrated, right? Maybe they work out a lot, or maybe they just love Coke and they refuse to drink water because they love their sodas. You see that a lot. DKA, what's something you see, and it is up here, but what's something you see in the urine? Ketones, that's how it will help you. In addition to knowing your sugar's over, it's very, very high, not just 107, but really, really high, you're gonna see ketones in the urine. So you're gonna expect to see urinalysis and looking for those ketones in the urine. We also wanna make sure we're checking their BUN and creatinine. I need to see how their kidney is functioning. Is it a kidney issue and their kidneys aren't filtering things properly and that's why they're in DKA? What is another one? Another person that you might anticipate. They're taking their medicine just fine. They could be sick, right? They could have just something simple as a cold or the flu. They're taking their meds right, but they're sick, and so they're at high risk for going into DKA. They could be stressed, really stressed, or they could be pregnant, and you have your what is it called when you have a patient that's pregnant and they have issues with diabetes? Gestational diabetes, right? They are at risk for going into DKA, and they've never been diabetic in their life, but because of pregnancy, now they are. So we're gonna make sure we're doing hourly glucose checks. You'll have it a DKA order set that comes with it, and it tells you if your sugar is this, give this amount of insulin. Kind of like your electrolyte, your MPP that you saw earlier. It's very similar. It'll tell you different insulins to give, different fluids to give, right? Because if their insulin drops too low because of the insulin we're getting, right? Clearly their insulin is jacked up right now. So if it drops too low, I'm not gonna just keep giving LR or NS, right? What do I want to give? D5. I might be wanting to give D5, give them a little extra sugar. DKA patients are a constant balance. You're constantly balancing the sugar, their symptom management, you're constantly balancing all of it, and sometimes they could be really sensitive to the insulin you gave them. I could give one person 5 units and this other person 5 units that are both DKA patients, and this one responds to those 5 units a little bit more intensely than the other one does. And they dropped a lot more. Because of that, because of the constant medication and constant fluids, you're doing hourly blood glucose checks. Hourly. They hate it, patients really hate it, so you have to make sure you educate them and you're not surprising them every hour. And they're like, you're here again. Tell them in the beginning, hey, you're in here for DKA, and this is what DKA is, and we're gonna be in here hourly. Unfortunately, I have to check your sugar hourly because we don't want you to drop too low and we don't want you to stay too high. So it's a constant balance. And because DKA goes into do you remember Rome, respiratory acidosis, metabolic acidosis? Because you're in metabolic acidosis in this moment, you need to monitor your ABGs. So you may call RT for that, right? Obviously we said, I gave you the answer, so endo and nutrition are gonna be up here. But you could also see potassium in there with it. Potassium, what did I say, an MI, you're high risk for, basically anytime you see potassium, I'm sure she talked about it in the MPP, you've gotta monitor what the potassium is. Check your potassium, because if you have potassium orders and it's in your order set, but the patient's potassium is really high already, I'm not gonna just do it because it's in the order set. Check your potassium, or else you can put them in an MI, or they could go into cardiac arrest. All right, goal, control the sugar. Pretty simple. Any other questions on this? All right, and this is second to last one. Definitely went over an hour. Let's talk about left-sided versus right-sided heart failure. Does anybody remember those?
Yes.
Yes. Tell me about them.
Left side lung.
Left side lung, exactly.
Left side.
Yep, I remember that too. That's what I literally got through nursing school with mnemonics. Like, that's the only way. But you're gonna see right-sided, you're gonna see a lot more JVD. You'll see generalized swelling, like ascites, generalized fluid. You'll see congestion in their veins. And left-sided is all about the lungs. You'll see some shortness of breath because of the fluid that they may have in their lungs, or some edema. They may have it may irritate the heart, and you've got S3 heart sounds. So when you're listening to your patient, you may hear that S3 that you don't normally hear. Again, people that are CHF, same as people that are at risk with CAD, unhealthy diet, hypertension, diabetes, all those same things, and non-compliant with meds. A lot of CHFers that you see come in hate taking their Lasix. They hate taking it because I gotta work. I can't work while I'm still going to the bathroom every 5 seconds. So you talk to them about compliance and you're like, I get it, that really does suck, having to take meds and having to pee that often. But you still have to do it or you're gonna end up back here every other week, right? So education is a big factor. Obviously cardio, but you can also see cardiac rehab. They may need cardiac rehab and that's a consult or referral that you may need to look into getting. Obviously dietitian, nutrition, are they eating too much sodium in their diet? They could be like, oh, well, I eat all these right things. I eat chicken, I eat all the, chicken and greens, but are they adding extra salt to it just to help it with taste? Water follows salt, right? When you think about swelling, so that may be something that needs to be addressed. BNP, we talked about BNP earlier. This is your go-to. You should expect to see your BNP here. And troponins, anything heart-related, you're gonna see cardiac labs, anything heart-related. We may do another echo, we may do a stress test, we may do chest x-ray, because you may see these things and be like, yes, this is heart failure and they're not having all these issues, but what's causing it? Is it the valves and we need to do the echo? Or is the heart just too stressed? Those kind of things. So these are things to anticipate. What meds do you anticipate? I gave you one of them. Lasix. What else?
Maybe like a beta blocker?
Yeah, you could see some ACE and some ARBs, right? You need to lower that blood pressure, right? Because prolonged blood pressure over time leads to heart failure. So if we're in the heart failure stage, we're already here. There was some issue with non-compliance on meds on hypertension, or they never went to the doctor, never realized it was hypertensive, those kinds of things. And we want them to be hemodynamically stable, right? We want them to be able to breathe, not have huge swollen feet. We want to get them back to as best as normal as possible. May not be completely back to normal in the hospital stay, but that's where you set up those consults, okay? Another patient, this is the last patient you'll see, is sickle cell. You'll see a lot of sickle cell patients. Who do you think, what is sickle cell?
Red blood cells are sickled.
Basic. Red blood cells are sickled. Who is at risk? African American population, yes. And genetics. People that have the history, their family history of sickle cell. Here's some factors in cold temperatures. You'll see a lot more in the winter. You'll see a lot more sickle cell patients than you would in the summer. But any of those acidosis, they could also have DKA, and DKA could trigger a sickle cell crisis. They could be under a lot of stress, and they're hard sticks too. So managing that is something that's definitely asked. What do they look like? What are their signs and symptoms? If I tell you have a sickle cell patient, pain, right? A lot of pain. What else? Shortness of breath. Think of a sickle cell crisis, right? Think of, let me see, sorry, I'm going back to my notes. If they're in a vaso-occlusive crisis, right, we're gonna see them having decreased circulation. So you may have like cold, or like they were not gonna have as much blood throughout their body because of it. You're gonna see like their fingertips are cold, decreased perfusion while you're looking at them. And what's causing the pain?
The sickle cells trying to get through.
Yeah, the sickle cell's trying to get through and it's not getting through, so it's causing some ischemia, right? That ischemia is what's causing this pain. And that'll lead into what we're gonna look for meds. Take a look at them if they're jaundice. They could be jaundice. When you break down, your body breaks down so many RBCs, you can get a little jaundice. So who's consulted? Hematology and cardiology, right? They're at risk. So you're gonna have those, definitely hematology. If it's some issue with joint pain, I didn't put it on here, but you may have they may be a PTOT candidate as well. You also may need to consult nutrition. They may not be hydrating themselves well. And if they're not hydrating themselves well, they're gonna be in more pain. What imaging would you order or labs? Okay. In your CBC, you may get your CBC, your white blood cell count, your H&H. But you're really looking for this CRC. So you may have a patient that has a history of sickle cell, but they're saying they're in a lot of pain, and then you get your retic count back and their actually not that bad looking, then we need to look into other avenues, right? The retic count on a patient within a vaso-occlusive crisis is gonna be really high. So, take a look at that as well as taking a look at kidney function, because processing those, your body processing those, RBCs that are sickled is gonna have issues. What meds?
Pain meds, fluids.
Pain meds, fluids, folic acid, hydroxyurea, oxygen, rehydration. They could need, if they're anemic, they could need some antibiotics, right? So these patients just got a lot of issues going on that could lead to a lot of things. So keeping them at bay, keeping their pain under control, getting that rehydration helps a lot with those passing of those cells, the clump cells. All right, those are through. So we're gonna look at a case study really quickly. I'm not gonna get you a full report on them, but I wanna talk out loud. I'll give you this patient and we can talk about using your MDDR. What things do you think will be holding up your dispo, okay? So this patient is a 65-year-old male, okay? He presents with COPD exacerbation, so that's the COPD patient. He's been in the hospital for 4 days, okay? He's got the history of COPD, hypertension, and diabetes. His vital signs are normal, 92% on 2 liters of oxygen, heart rate 85, BP is 140 over 92, 20 respiratory rate. And he's anticipated for dispo today for you. What do you anticipate would delay his discharge? Looking at your MDDR, what are some things on the COPD patient that you think?
His signs and symptoms of infection.
Okay,
And you said he was on oxygen, will he need to go home on that?
okay, who would you contact for that? Case management. RT, yeah, you can talk with RT, because another thing is that's on here is weaning off of oxygen. Are we weaning off this COPD patient off of the oxygen, or are they staying on oxygen and going home with it? You kind of have to assess that when you're looking at your patient. 2 liters, it's not a lot. Take them off, test it, talk with RT, see do they need the 2 liters, or are they maintaining at least a 92 without it? What else?
So, you say he's going home?
That's anticipated to go home,
So I
yes.
guess if he has a ride?
Yeah, right? And how is he gonna ambulate at home? How is he gonna be mobile at home? Was he mobile before and now we're sending him and he hasn't even been walking? If so, we need to get PTOT's recommendation, right? What about meds?
You said his blood pressure was high, does he is that his normal? Does he need to
Yeah.
be on that?
Those are things you need to ask, right? I need to find out what is it. You look through your blood pressure, look through your flow sheet and see all the vital signs. Is he already taking meds and we're still at the 140? If so, are we okay dispoing at 140? Right? Some hospitals and usually have parameters that you can't dispo on, even if the doctor will tell you dispo. We can't until we get this lowered. And then are we gonna dispo right away once we lowered it and have one vital sign that looks good for dispo? No, how is he gonna maintain those? Do we have his home pharmacy, right? Do we have a pharmacy listed? Do we have, the thing that people always leave without getting is prescriptions? Do we get the prescriptions of everything sent? They patients will be like, I'm not leaving till you get my prescriptions. So making sure you communicate, educate, yes, it's being sent to this pharmacy, is that correct? Doing those kinds of things. Good, those are all things we gotta monitor. All right, and then this case study, number 2, similar situation, okay, we're gonna go through the patient. It's a 61-year-old female, she presented for a status post-ischemic stroke, hospitalized for 3 days. History of hypertension, that's it. Vital signs are stable, heart rate's at 100, another 140 over 90, 16 is the rests, 98 on room air, okay? They're supposed to be going to dispo today. What do you think will delay that discharge? What can you anticipate going through your MDDR?
Acceptance to a facility?
If they need to, they could have zero neuro deficits. But a neuro assessment, right? Is neuro okay to clear them? What is their NIH score? Those are part of your neuro patients right there. NIH, lipids, are all those being managed? Some of those meds were given IM or IV. How are we gonna get them to go home on some of these, right? So how are we converting them to PO? If they've had a stroke, what are they at risk for? I think very simple.
Aspiration.
Yeah. So we make sure that the assessment got done. Falls. They're at risk for falls. When you see a patient, it's easier because they got the socks, so it's easier for you to identify that. But if they're a fall risk patient, how are they gonna be mobile at home? Do they have carpets at home? How many stairs do they got at home? They gotta go up and down stairs, you know? How is that gonna be managed at home? Is the consult done for who? PTOT, did they put their recs in the chart? Sometimes it takes them a while to put their recommendations in the chart, and dispo's already come up. So we need those recommendations to set up case management. Maybe they need to go home and get a walker. Maybe they need to go home with a wheelchair. It's gonna take a while, but dispo's up. So keeping an idea, if you have the idea that they're gonna be discharged, try and get those things all sorted out on what your to-do list for the day is. Yes, you need to go in the room, give your meds, your 9 a.m. meds, you know, your labs, but make sure you're putting those on your to-do list, on your brain of what needs to be done. All right, these are some references. One of my favorite books is Sheehy's Emergency Care. I think it's good not just for ER nurses, but for everybody, because it breaks it down just like we did. Just like your concept map, it breaks everything down pretty easy. Oh, sorry. Thank you. Pretty easy. Any questions? Okay. Well, thanks. That's it for me. I do okay, guys? Yeah. It's kind of boring, but